Mechanical ventilation is crucial for patients unable to breathe independently. It involves using machines to support or replace spontaneous breathing. Sedation is often necessary to ensure patient comfort and compliance with ventilation. Understanding the pharmacokinetics and dynamics of sedatives is essential for optimizing patient outcomes in the intensive care unit setting. Mechanical ventilation and sedation are crucial in intensive care unit settings. Pharmacists and clinicians must understand ventilator settings, sedation protocols, and patient-specific factors to optimize care. Effective management minimizes complications, ensures patient comfort, and facilitates recovery. This knowledge is vital for improving outcomes in critically ill patients. Sedation and analgesia in critically ill patients aim to ensure comfort, safety, and effective mechanical ventilation. Pharmacists must review sedative pharmacology, apply assessment scales for sedation depth and delirium, and optimize sedation practices. Key responsibilities include medication management, monitoring patient responses, and collaborating with the healthcare team to enhance patient outcomes. Sedation in critical care aims to ensure patient comfort and safety by minimizing anxiety and pain while maintaining reflexes. It enhances ventilator synchrony, optimizing oxygenation and reducing dyssynchrony. Metabolic benefits include decreased oxygen consumption and stress response. Additionally, sedation secures devices, preventing accidental removal, and supports early recovery by reducing delirium risk and facilitating weaning from ventilation. In critical care, selecting appropriate sedatives and analgesics is crucial. Propofol offers rapid onset and minimal accumulation, while dexmedetomidine preserves respiratory drive. Midazolam is for short-term use due to accumulation risks. For analgesia, fentanyl is potent with minimal hemodynamic effects. Morphine has active metabolites, and remifentanil is ultra-short-acting. Updated guidelines emphasize multimodal analgesia and delirium prevention. The Richmond Agitation Sedation Scale, RASS, is the gold standard for assessing sedation depth, targeting a range of 2 to 0. The Sedation Agitation Scale, SS, serves as an alternative. The Confusion Assessment Method, CAM-ICU, detects delirium, performed twice daily. Sedation vacations are structured protocols for daily sedation necessity assessment and weaning potential. Prioritize pain management before sedation using validated pain scales. Employ fentanyl or morphine as first-line analgesics in the intensive care unit. Consider a multimodal approach with acetaminophen, ketamine, or gabapentin for specific cases. This strategy reduces oversedation risks and helps prevent delirium. Delirium prevention in the intensive care unit involves targeting light sedation with a Richmond Agitation Sedation Scale of 1 to +1, avoiding deep sedation unless necessary. Benzodiazepines should be avoided. Opt for propofol or dexmedetomidine. Maintain circadian rhythms through lighting and noise control. Implement early mobilization protocols and ensure pharmacist surveillance for medications that heighten delirium risk. Pharmacists play a crucial role in optimizing dosing by verifying agent selection and infusion rates tailored to patient-specific factors. They adjust medications for organ dysfunction, ensuring compatibility with concurrent infusions. Safety monitoring is essential to prevent adverse effects like hypertension and bradycardia. Additionally, pharmacists educate staff on evidence-based sedation protocols and monitoring techniques. For a 58-year-old male on mechanical ventilation, implement daily sedation interruption to assess sedation necessity. Transition from midazolam to dexmedetomidine to lower delirium risk and enhance weaning. Start fentanyl infusion, prioritizing analgesia before adjusting sedatives. Monitor hemodynamics, conduct confusion assessment method for the intensive care unit screenings, and evaluate readiness for liberation trials.